My name is Lynda Dee. I'm from AIDS Action Baltimore, and I'm co-chair of the DARE-CAP with Danielle Campbell, who's also my co-chair. Now, the name on this slide is Boris Joel, because these are Boris's slides. Now, I put a little color in them because they were a little dull, and I really pared them down because we don't have a lot of time. So we had a meeting, a consensus meeting, to try and figure out what's the best way to do these ATIs, what's the best way to decide when we need them, what's the best way to decide what's safest, and to maximize the data that we get from them. But mostly, as far as the community is concerned, what's the safest way to do them? So Boris's name is on them, not mine, because they're really his. We had this consensus meeting in Boston in July. It was really well attended. It took quite a few months. This community summary side, you can look at it while I'm talking, to get it together. But we had a really broad array of stakeholders. And, you know, as I said, we've been doing a lot of advocacy leading up to this point. So we were really fierce that day. You'd have been proud of us. So the reason that we need ATIs is it's not, you know, latent reservoirs, which is the reason that we can't cure HIV, these bloody little things that just come up and go away and come up and stay up, and they just are not, our antiviral armamentarium is not effective against them. So what we need to do is measure these latent reservoirs, just like you get your viral load measure. And if you didn't have viral load tests to measure your virus, you wouldn't know if your antiviral medication was working. So we don't know, and we don't know yet if these interventions will be working because we have nothing to measure them with. Plus, I'm telling you, in the future, when I'll talk about immunologic trials later, but maybe I'll save that for later because we're in a bit of a hurry. So the purpose of this meeting was to try to come up with a set of recommendations that most people could live with, that again maximizes our knowledge and minimizes the risk to participants. We did have a lot of consensus on lack of alternatives, on no one-size-fits-all, on different risk mitigation strategies, including the inclusion and exclusion criteria. Really, we were all over the place with the restart criteria, and really all over the place with PrEP and whether, and the methods, the best methods to give PrEP to partners and participants so that they don't become infected during this period. Now, this 23 number, it might be a little wrong. Richard gave us that, but this was back in July, so I'm sure there are probably a few more studies that include analytic treatment interruptions. And again, the problem was that these studies are all over the place. So some have very different criteria. There were no standards, so we really wanted to try and bring people together, get recommendations together, and do our best to you know, minimize the risk for patients. Here are the workshop participants. The meeting, whatever, what were we called? I forget what we were called. The people that got the meeting together are in pink. So again, what we're going to go over here today are benefits and risks, risk mitigation as far as the eligibility criteria, and as far as the restart of antivirals once the viral load rebounds. And we had a moderated session, a number of moderated sessions, and ethics, I'm sorry, a moderated session for each of these, and we actually voted at the end, so I'll show you how people voted and the results of that. So, no, see, you know, I think I'm going to be running out of time. So, no robust markers. You know, we decided that the onus is going to be on the investigators not to use these ATIs for every single trial, but only when we were looking for some sort of an immunologic reaction, so that you didn't unnecessarily subject people to the risk of being going off therapy, and that they need to come up with a justification for these things before you made a go, no-go decision, including doing animal data to make sure whatever the intervention you were using is safe. So there are two kinds of ATIs. One is not so risky. The minute your viral load rebounds, you get back on therapy. So that's kind of easy, all right? The more difficult and the more risky and controversial ATI are the set point ATIs, where what they're trying to do is stop your therapy, give you interventions, maybe your viral load will come up a little bit, and the interventions will hopefully make you be able to fight a virus with your own body. So they're going to have the virus come up to see if your own body can make it come down. So that means that you're going to be off therapy longer, and the concern for the investigators is that what they're trying to do is make you what's called post-treatment controllers. After you finish with this trial and this intervention, your own body, again, will be able to combat the virus. And maybe with periodic treatments, we don't know any of that yet. That's really not the point of this talk. But anyhow, in order to make these post-treatment controllers, you really are going to have to give the intervention a little bit of time and watch to see if the virus goes up and then comes down. So the trick, and what nobody could agree to, was what the stopping point should be before we restart. Stopping before we restart, and you know what I mean, right? So some of the potential risks for ATIs are acute retroviral syndrome, you know how sick people get when you first become infected, increases in the size of the viral reservoir and viral diversity. A lot of the docs are saying now that people who, the reservoir size has not been that increased that much, but I think it's early days. So, they all say that their trials are working fine with no problems. Anyway, we have resistance issues. So if you're off drugs, then does resistance happen? Are you going to have drugs to take when this is all over with? So there's some criteria later on that I'll get to that addresses that. And suppose you have a neurologic, cardiovascular, cancer, liver, renal disease, kidney disease. Inflammation is a big problem when you come off of your drugs. So I'm glad people are shaking their heads, so I know that I'm not going too fast. And of course, the really big bugaboo and the big black hole is transmission during viral rebound. So here was the first thing that we voted on. So the FDA considers people with HIV that are not sick to be healthy volunteers. So that means you have to have a risk benefit. You can't start giving them poison if they can take one pill a day and be fine. So that's, I think, the best rationale for looking at healthy volunteers first in these relatively healthy people in these first trials, and not having the consideration be, well, we just need to enroll the trials and we can enroll more people with 350 CD4s rather than 500. This was the biggest battle we had that we actually won, and again, because the researchers, if they want the criteria to be anybody with 350 or above can be enrolled in these trials, and we really were very much against that, argued for 500, and we got our way. So how everybody that was at that meeting, raise your hand. So it was a number of us there. It was more of us than are here today, but we fought the good fight, and we really, that was the thing that I'm the most proud of.
Can you repeat that? I'm not sure.
Oh, okay. So in other words, the investigators, most of the investigators want the criteria to be that you have to have at least 350 CD4s to get in these ATI trials. All right? The community and other researchers, not just, not all researchers think the same, obviously. We wanted it to be the criteria to start with 500 CD4s. And unless you have a CD4 count of 500, you're not eligible to enter these trials. Because remember, your CD4s are going to go down, your viral load's going to go up. So if it starts at 350, it's too close to a danger zone for my liking anyway. So it was close, but we won this argument, which I think is probably one of the most important. Yeah, we deserve a clap for that, believe me. Not just me, but it was really, we had a hard fight on that. Richard was very helpful with that too, looking at all the different studies and bringing a lot of info to the meeting as we went. Yeah.
Was there any talk about CD4 Nader?
Next. It's coming up, I promise. So then we talked about strict inclusion criteria. The Naders up there, and there's another slide just on Nader. So they decided on 200. We've tried to get 350, but I don't know. This is a much more, I'm not absolutely convinced that this is as important as the CD4, but nobody knows. I would like to have it to have been 350, and I think that we'll still argue for that, but that's a big hung jury kind of question at this point. So history of AIDS defining illnesses. You can see, do I have a pointer? You can see the yes, no, and what got the most votes. Okay, All right, so cancer in the last 10 years, drug resistance to, it's like my little cat pointer. Oh my God, I forgot to leave it out for the cats there. Oh well, hopefully she'll find it. Yeah, so anyway, we talked about resistance. So a person would have to have activity, or two other classes of drugs would need to be active, or else they wouldn't be able to be enrolled in this study. So they have an option if they become resistant to the medication they started with. So we did fairly well with all those. Coronary artery disease, again, because of the inflammation aspect of this, kidney disease, and this one as well, this partner. I'm not going to go into that a whole lot now because I'm going to run out of time, and it's discussed more later. But if a participant proves that he can't, that he's getting STIs and different things, and the idea that he might infect somebody, and at the discretion of the investigator, should he be in or out. So that was still no, not using or able to use PrEP. But we'll discuss that a bit later because that's a huge, huge issue. So what is this one? Yeah, was that enough of a Nader response? You have, does that answer your question about the Nader?
Yeah, it doesn't make me happy.
Yeah, me neither, but, so.
So Lynda.
Yeah. Hi.
What reason did the FDA give saying that 200 would be safe?
It wasn't the FDA, it really was the researchers. That they're doing all these studies, it doesn't make any difference, that it really has no effect on the overall outcomes. And to us, it's more like, well, 15 minutes, I really better get started. Can we talk about this later, because I got a lot more to go. The thing is, we got more work to do.
Go back to that. Your ETA, you go back to where you were before you stopped.
Yeah.
So I don't agree with the...
I don't either. But that's the one, I think probably the biggest one we lost. So no clap for that. Clap again to give us some energy to keep fighting, huh? So anyway, then we talked about monitoring and how often we drag people in to be tested. So the consensus was once a week for the first 12 weeks and every other week thereafter to actually get a blood draw to see if you have rebound. And then we also talked about home testing considerations that might be appropriate for some people. We're not there yet either. So the restart criteria was all over the place. We talked about, suppose the CD4s go down to 350. Suppose the percentage goes down to 15%. Or if somebody had 1,000 CD4s and they had a 30% decline. If there was evidence of unprotected sex, should we restart this person? And I think most people thought that was the case, but we're going to see some voting on all of these things. Okay, so here's where they ended up, which was really a surprise to me. Instead of, they were more safe here than anywhere. If you have a viral load of 1,000 for 4 weeks or greater, you need to get restarted. So anybody that wants to make you a post-treatment controller and try to see how if we can make your viral load go down on its own after the intervention, they wanted this. And I kept saying, well, why 50,000? Why can't we try 35 at first and try it for a week or two or whatever? But, tend to be hardheads. So we didn't get nobody won this one, I think, except maybe the patients. All right. So the ethics. Well, we're doing pretty good. We don't have a whole lot of slides left. We talked about the problem of the word cure, using cure on the trials, on the informed consent forms. It reminds me of phase 1 trials. Why do people get in these trials, Mostly because they're good and altruistic and wonderful people that are willing to help. But we just want to be sure that they have a reasonable expectation of what's going to happen and that they know there's going to be no benefit for them. So we thought the best way to do that is not stamp cure all over everything. People have a tendency, you see that, and that's all you see, some people anyway. So we came up with a number of different terms. I don't know that any of them are perfect, but this is what they were. Drug-free long-term control, undetectable off treatment, viral suppression off treatment, art-free viral remission, and then just remission. I think remission is probably not really the most popular from the potential participants that we spoke to. It sounds like cancer, it sounds like you're still sick. How many people don't like the term remission in this? So it's, how many don't care about it, that it seems okay to them? So it's about the same. Anyway, I think we'll probably try and stay away from that. Okay, and the other question is, the other big ethical issue, is there a scientific justification for placebo control? So the big deal with that is some of these things are first in humans, that we don't know if they're going to work. We want to be sure. We're doing evidence-based research. Placebo is a red flag for many of us, but then Tony Fauci from NIAID had showed the results of this vaccine trial, and had there not been a placebo control, it would have looked like the vaccine worked when it really didn't. So then there's an argument that it's unethical not to use a placebo if we're going to get wrong results. So I think people are coming around to understanding that. Maybe not liking it, but I think, until we know more about these drugs, placebos might be indicated in some trials at least. The really good news, and I know Karina's very happy about this, that they voted over, oh no, this is the wrong one. No, this is the one after this, the last slide. Here comes the PrEP trial. Well, Christ, if you ask a community person, should you offer them PrEP? Everybody says yes, offer them PrEP. Do as much as we can to help the participants. There were some investigators, now not in the room that day, but it was like, I thought it was going to be a food fight with a couple of them. I won't say who or where they're from, but they were unhappy. This is not our responsibility. This is the patient's responsibility. We're good. So anyway, I think this is going to be future advocacy for us. I was talking to one of the MDC cabs the other day, and there was somebody there from Thailand, and we said, well, how did we asked him, how do you do it in Thailand? And really, in Thailand, they're so wonderful there. We have our PrEP shop right next door, so it's very easy to do a warm transfer to another department. And our joints have a tendency to be huge, university-based institutions, and maybe PrEP's on site, and maybe it ain't, so it's probably a little bit more complicated. So I think it's painfully obvious that what might work for Baltimore or Washington or Pittsburgh or anywhere else might be different. But I think the bare minimum at this point is that we have to insist that investigators at least give the partners like a sheet of facts about how they can become infected, where they can go for testing, treatment, and PrEP access, phone numbers, and all of that sort of thing. So I think our role or our job is going to probably be how to push that envelope to make that PrEP even more accessible. And I think we're going to have to do it at individual sites because they're going to all be so different as to where PrEP is available and that sort of thing. So, and this is the one for you, Corinne. People voted, you can see overwhelmingly that social science, behavioral ethics questions, and studies, surveys should be included in these trials. So you know how well the CDC, I can't believe I'm giving them a compliment, but they've done pretty well at looking at behavioral research in PrEP trials. So we need the same thing for these ATI trials to figure out what's what and how people feel about this stuff. So yay for Boris, he was the champion on this. He's my ATI hero. And I guess we still have a couple minutes for questions.
Lynda,
yes.
Are you prepared to talk about the one?
I can. Do we have time?
Yes.
Should we see if people have questions first?
Yeah, sure.
Oh, it's okay, we're good. So, this is going to be really fun. So, all of a sudden, out of the blue, about 10 days ago, this page and a half paper came across the wire from France. Unintended HIV transmission in an ATI trial. Well, so everybody was like, what happened here? So, first of all, there are a lot of confounding factors, and it's a little salacious in that the method of transmission was supposed to be cunnilingus. Now, the woman was HIV negative. They were heterosexual couple, and the infected partner was the man. So cunnilingus is pretty low risk, period, let alone going that way. So nobody can stop talking about that, all right? Which is really, who cares? She got it. What do we do to fix this now? And how can we fix this in the future? But I mean, you can't help commenting on that. I won't even say, I should stop right there. So then they said, well, he was an AIDS activist, so essentially almost saying he should have known better, like they used to say about people with, you got a viral rebound, it's because you didn't take your medicine, So, in other words, and then what year he got involved with it, his partner, all this information, everything but his shoe size, okay? And we were like, what the fuck are you telling all these people all about this guy, and his partner? So then he had uncontrolled diabetes. What is he doing in this trial to start with? Then they were both depressed, and we were all depressed after we read this. And, I kind of thought, well, you can't keep everybody out of the trials that are depressed. I mean, what's the, I said two-thirds of the country's been depressed since 2016. And then somebody was, well, we really have to include depression. And then Richard Solomon said, well, maybe we should ask them to use validated scales of depression and decide whether people are in or out of trials. I mean, usually we try to advocate for people to get into trials. Anyway, so Giulio from Italy knew this guy, so the PI, the French investigator, so we asked him these list of questions that essentially address what I told you. Well, he was like a lawyer, very evasive. Oh, well, I don't know this guy. He was from another site. And well, maybe I said too much, but I'm not really sure. And Richard thinks another paper's coming out. So we're going to write a response, but I think we're going to mention the things that I said, but we're going to concentrate because I really believe this is a golden opportunity, conolingus or otherwise, to show that these are real people. This is a real risk. And people can become infected, and it's our job to do the best we can to make sure that people don't become infected. Of course, the elephant in the room is some people have more than one partner, so it gets a little complicated, as we all know. Any questions about that?
So,
We got 5 minutes. You got plenty of time.
I'm going to stand on this. I actually was in the car with Doug Nixon when I started to get the second wave of responses from this article. My initial response was certainly the cunnilingus part. You kind of go, okay. Beck Young wrote a paper at one point that talked about the likelihood of cunnilingus transmission, but I won't go into that. Then I looked at the depression scale, and I won't go into that. And then I won't go into the leveraging his activism and what importance that played, so I won't go into that. But what I think that the challenge for me in it all was what I felt like was the immediate frenzy kind of that we did in our response to it, and how I think that we collectively should certainly develop a response. But I think that the diabetes and the depression scales are important. I think that there is something there. I think that when we look at who is and how trial inclusion and exclusion criteria are done, we don't look frequently at things like depression scales, diabetes scales, but that there is some sort of malfeasance that was done when an author has now published that paper, and that paper has now gone around the globe, and there's some leverage that has been given to this individual's activism as his clout, as like he should have known better. This is now going to be known as the he should have known better. Right? And I'm like this, I mean, so we sit in this room and we kind of circulated it as well, that's not right. You shouldn't have not necessarily known better. And we all kind of have now siphoned through this, and some academics have siphoned through this as, no, that's not right. But that's us in this group. There are a bunch of people who have now taken this as Bible and verse. So I think that we can't just say, no, we're going to go this way. we have to address the, no, he shouldn't have known better.
Yeah, yeah, we will.
I think we can't
I
just
promise.
ignore it.
I promise we will.
Intervene for a second, because Livia, we're very fortunate to have Livia here from the NRS, and
I am from the NRS, but.
Oh my God.
I am,
You still got time to run.
I am from the basic research branch, and I'm not, but I remember when this first came up, even this was a therapeutical vaccine trial from the Vaccine Research Institute, which is sponsored by NRS, which is where I work, okay? So I remember the first thing is, why didn't you put people in PrEP, the partners in PrEP? So the answer of the investigator was PrEP was not yet available at the time, and they were.
And I checked and it really wasn't at that time in France.
Yeah, it wasn't, but anyway. But, and then the activist part, sorry, I'm learning it here. I should have read the paper, but I cannot understand that they would blame the guy for being an activist, or the opposite way, like if he was an activist. Is this the French investor, my colleagues, the ones that blamed the...
Yeah, and at the end, also said that, well, there are some dangers, some side effect dangers of using PrEP, risks from using PrEP. And I thought, okay, now let's really slap us in the face. So, Corinne, you had your hand up for a while.
Things lost in translation from
Yeah.
That's
Could be.
So I think we have a unique opportunity as a field also now. It's like, what can we learn from this case? There was another paper at Palich et al. That was the biomedical piece of it that said that bowel rebound is very quick in semen and blood and very unpredictable. So I think we can learn something from this. And this is also a case that tells us that we need to integrate the biosocial, psychosocial aspects of the ATI. We're dealing with the depression, and I think it's important to integrate behavioral and social science also to understand the behavioral part of this. And we have a unique opportunity to help strengthen reporting guidelines. How do we report these cases to ensure that they're non-stigmatizing in the future? Imagine if it had been a woman who had transmitted HIV, or anybody. We have to be...
She'd have been the next Joan of Arc.
I think, okay, we need to maybe come to consensus as a community as to how we should report this and just deal with this in the future. And there's the PrEP paper in the press, so we will circulate it as soon as it's available. But we also need a lot more information about PrEP efficacy in the context of these ATIs. And this is where we will need research across studies.
Yeah, and we're going to have to, each place is going to have to come up with a solution for their whatever.
Yeah.
But Tony, all your points are well taken. We intend to address all of them. We've been in touch with JID. Corinne emailed the editor. They're happy to get a response from us. So.
But I think also the other piece of this is that to not make an assumption that the reporting was correct, right? We make an assumption that the individual reported his and her behavior to the scientist, that this is all we did. I mean, I think we say that this is what they reported, that their only exposure was cunnilingus. I mean, maybe they reported that because that's what was going to keep them in the study, right?
Yeah, we'll probably never get to talk to them.
Exactly, and I think that we have to, acknowledge that sometimes people tell the scientist and tell the researcher what they want to hear to stay in the study. And this happens, and it happens often, and that's a part of the behavioral and social sciences element that we have to do too. So I don't know kind of what the decision-making is on who's a part of writing this.
Well, I think what we're going to have to do, because we're going to have to do this quickly, is we're going to circulate it, and whoever wants to sign on can sign on.
All right, could you make sure that,
Okay, how much time do we have, Michael?
We're over time. Let's take this one last question.
I think that you should contact, there's TRT5, what's
Yes.
TRT5? You should contact them, because they might have been called into the, the independent, to know if they were in the independent.
Yeah, maybe you can tell us how to do that, who to contact. That would be helpful.
I have the addresses.
Can we take Laurie's last question?
Sure.
Go ahead, Laurie.
I was just going to say a couple things. So one is, I think the whole he should have known better, he was an activist is nonsense.
Right.
And I also think that anybody who's knowledgeable would say, well, cunnilingus, who needs to worry about that?
Absolutely.
Yeah.
So, as an educated person, that's not something that you would necessarily consider a very risky activity.
Right.
And so that should also be put into context.
Plus, it's a lot of personal information that would allow you to maybe figure out who this person was.
Yeah, but there were 1,000
Yeah.
people wrong with the article. But the other thing I think we really need to be careful of in our desire to protect partners is that we should not assume that most people in trials necessarily are in these mutually monogamous relationships or have a steady partner. And I would not want to see us excluding people from participation
Right.
because they happen to be people who choose to have
Correct.
multiple partners in their lives that the study investigators cannot be expected to protect.
Right.
So then, what is it that we would want to ask of participants while they are on an ATI?
Well, this is the last thing I'll say. In the study, at the meeting, what they said was if somebody comes back with a sexually transmitted disease during the ATI period, you'll know he's being active without, taking precautions, he or she, and then they're out of the study. So,
And they need to test for
I'm
that.
not sure that-
Except you don't know if the partners are on track.
say that again, Simon?
An STI means you don't know whether their partners are on track.
Yeah, no, believe me, it's a million bugaboos. So I think I'm going to get the hook if we don't stop.
Yes. So
Everything else has happened to me this morning. I want to get the hook.
Thank you, Linda.